Hello everyone, welcome to Ophthal Bytes by Eyetoday. Our topic for the day is Best Vitelliform Macular Dystrophy. Best dystrophy is a common macular dystrophy seen in 1 in 10,000 people. It's inherited in an autosomal dominant fashion and caused by mutations in the BEST1 gene which codes for the bestrophin protein. The normal function of bestrophin appears to be regulation of the ionic milieu in the retinal pigment epithelium and the subretinal space. Hence, mutations in the gene can cause impaired ionic flow across the retinal pigment epithelium and alterations in the adhesiveness between the RPE and the interphotoreceptor matrix. It also causes decreased phagocytosis and hence increased RPE lipofuscin and accumulation of pigment-laden cells and material in the subretinal space. Macular lesions that are most characteristic of the disease are known as vitelliform because of the egg yolk-like appearance. Lesions are round or oval, yellow, slightly elevated and centered on the fovea. They are a few hundred micrometers to few millimeters in size. Larger lesions can be seen within the first few years of life, whereas the smaller lesions develop after 20 years of age and hence known as adult vitelliform lesions. In many vitelliform lesions, the yellow material gravitates inferiorly in the subretinal space, giving a pseudo-hypopyon appearance. Visual acuity is slightly affected in this stage. Some lesions develop subretinal and sub-RPE fibrosis, atrophy and hyperpigmentation, known as a scrambled egg lesion. The visual acuity of the patient tends to decrease in this stage and is also known as VITELLOERUPTIVE stage. In patients above the age of 60 years, geographic atrophy can occur, choroidal neovascular membrane can occur. The visual acuity tends to drop in these patients. In a few patients with vitelliform lesions, even a modest blunt trauma to the head or the eye can cause a subretinal hemorrhage. Fortunately, these hemorrhages resolve and good vision returns even without any treatment. OCT demonstrates hyperreflectivity of the vitelliform material in the subretinal space. Another lesion which is seen in these patients is a fibrotic pillar that develops in the sub-RPE space. It is hyperreflective on OCT and seems to elevate the retina like a tent. It's flanked by clear subretinal fluid which is hyporeflective. The pillar is associated with a relatively rapid loss of yellow pigment from the lesion and a drop in the visual acuity. Fundus fluorescent angiography shows corresponding hypofluorescence due to masking. In some patients, the lesions briskly and completely fill with dye, mimicking a serous pigment epithelial detachment. In fundus autofluorescence, the yellowish material is intensely hyperautofluorescent. Electrooculogram is abnormal in these patients. The Ardens ratio is less than 1.5. The only clinically important role of EOG is diagnosis of Best dystrophy, to differentiate it from other pseudovitelin dystrophy and for detection of carriers. There are additional phenotypes associated with mutations in BEST1 gene like autosomal dominant VITREORETINOCHOROIDOPATHY, in which the patients present with lesions similar to Best dystrophy along with 360-degree peripheral pigmentary retinopathy, choroidal atrophy, microcornea and shortened axial length. In autosomal recessive bestrophinopathy, solitary and multifocal vitelliform lesions can occur associated with flecks within and outside the macula. Subretinal fibrosis appears to be more common in this condition. Early stages of the disease do not require any treatment, but protective eyewear and helmet is recommended for all sports to avoid any trauma which can cause a subretinal hemorrhage. In CNVM secondary to Best dystrophy, anti-VEGFs have been used. That's all for the day. Let's meet again with yet another interesting topic. Thank you.